My name is David Armstrong, and I'm the Director of the Health Workforce Tactical Assistance Center, and welcome to our virtual meeting. This meeting is focused on growing, sustaining, and supporting the birth doula workforce. I'm going to go ahead and turn the event over to today's moderator, Marieke van Eijk. Marieke is from the University of Washington's Center for Health Workforce Studies. Marieke?
Thank you, David. Thank you all for joining us today. It is a pleasure to be moderating this panel, and I would love for you to have a better sense of who you're talking with. So I would love to ask each of our panelists to shortly introduce themselves. And so, Amy, may I start with you?
Hi, everybody. My name's Amy Chen. I'm a senior attorney with the National Health Law Program, and I'm based in Los Angeles.
Thank you. Grace?
Hi, I'm Grace Gunther. I'm a research scientist at the University of Washington Center for Health Workforce Studies.
Thank you, Grace. Paula?
Hi, everyone. My name is Paula Kett, and I'm also a research scientist at the Center for Health Workforce Studies at the University of Washington.
Thanks, Paula. And Sabia?
Hi, everyone. I'm Sabia, she, they pronouns, and I'm the CEO of Birthing Advocacy Doula Trainings and For the Village.
Thank you so much, everyone. So like David said, also for the audience, feel free to add questions or comments in the chat, as well as raise your hands or any other way you can ask questions. And so today's panel is a follow-up on a webinar that was organized earlier regarding the doula workforce as well as Medicaid expansion. And we had a lot of questions remaining. So today's webinar is meant to more deeply engage with questions you may have regarding how to really support birth doulas in the breadth of services that they provide. How can we work together to create a more sustainable doula services, and also think with the doulas on how to improve maternal health outcomes. So that's why I'm going to give every panelist some time. I have a question for them to start our conversation, and then I would love to help you answer any or ask any questions that you may have. So again, you can raise your hand. It's in the bottom of your screen. Under the directions, I will scroll through my screens and trying to get as many raised hands as possible, or feel free to add it in the chat, and then I will read your question. So I would love to start with Sabia. Sabia, you have such an amazing background and so many initiatives really helping to improve maternal health outcomes, especially among BIPOC communities. Like you said, you're the CEO of Birthing Advocacy Doula Trainings, and also the author of an upcoming book, Birthing Liberation. And also from your work as a full spectrum doula, can you share a little bit more about really the breadth of services that doulas provide?
Yes, so full spectrum doulas, when we talk about doulas, we generally start from the definition of a non-medical support person that's helping a person to navigate, the information, the process, and the understanding of the experience that they're going through. And I think that specific definition is very simple. It doesn't really show like the full expansion of the work that we do. And so, of course, we're there to help through any experience, whether it be birth, whether it be postpartum, loss, miscarriage, abortion, surrogacy. I also do death work, right? So there's actually this full spectrum of experiences that we all go through in life at some point or another. And then the other part too is like the details as to which we get into. So in my course with BADT and our full spectrum doula training, we talk about disparities, we talk about birth, we talk about the things that I think are pretty obvious to folks, but we also get into like food insecurity and what does that mean to have a resource for that, right? We get into understanding like the intersection of the different systems that work with our clients, especially depending on their identities, where they're from, right? So child protective services, law enforcement, like we talk about, we also have to be aware of domestic violence. We're also aware of mental health things that may be going on. And the thing that is really important about, that I think is so important to the work that we do with doulas, is that a lot of times we're the first ones that are going to witness any of this, because of our connection to being in a home with the client, because of our ability to, our client's ability to just text us when something is happening, call us when something is happening, really being on call and being responsive to the client. A lot of times we are from shared communities, so there's more vulnerability in our conversations with our clients. So sometimes I'll walk into a space like, oh, this is going to be an easy postpartum situation, and then I leave and I'm like, oh, this is a food insecurity issue. This is a housing issue. This is a mental health thing happening here. There's a domestic violence situation happening here, right? And then I serve as a connector of like, how do I get these resources to my client while still maintaining our trusted relationship? So we kind of do a bit of everything. And I think, you know, again, that simple definition doesn't nearly define all the ways as to which doulas come to serve their communities.
Sabia, a follow-up question, and then I will turn to Amy. So indeed, the non-medical support person definition is too stringent. It does not cover. Would you have like a one sentence that really describes the range, the full, the breadth of what a doula does?
Is that a question for me? Because I'm ready for it. Okay.
I mean, and it's a difficult question. I apologize, but yeah.
So I would say, when I think about it, you know, I don't know exactly what I would call it, but I would think that it would have to do something with, I don't know, when I think about doulas, I think about like the great leveler, right? Like when we talk about water, right? How water, like, you know, falls into these pieces, right? And it just gets into these pieces that other people can't reach. And I feel like that's what doulas do. We're like the great leveler, right? So we have these, we know that there's a medical system that's interacting with our clients. We know there's a housing system, like all these systems, but our like gift, and it comes with a lot of hard work, is being a great leveler. It's like, how do I make all of these things, which are very much out of our control, make some type of sense so that my client can move through whatever they're experiencing in the best way possible?
Yeah, thank you so much. Amy, you know, many states have started to include the expense, or have expanded Medicaid to include birth doula services, and other states are in the process of sort of providing some kind of policy and reimbursement, which is a trend that is very much welcomed, in partly because it addresses the fact that a lot of communities that face so many disparities. One of them is lack of access to affordable care. At the same time, there are also a lot of concerns because it does not fully support birth doulas or full spectrum doulas in a more sustainable way. Many of the times, the reimbursement does not cover, like Sabia said, the breadth of the work that they do. So in your experience, Amy, would you have a few examples that in your understanding sort of work towards a more sustainable way of supporting doula care?
Sure, yeah, and I can just do like a quick overview also of sort of like where we are in terms of coverage. So, you know, right now, as of March 2023, it's exciting to see that over half of all states, a total of 28, are taking some action towards, you know, as Marieke mentioned, Medicaid coverage of doula care. This is either through direct implementation or in some cases, some adjacent action, like, for example, setting up doula advisory boards or, you know, convening stakeholder work groups through legislation. So right now, you know, there's currently 11 states plus Washington, D.C. that are actively, that have actively implemented Medicaid coverage for doula care. I will say the ramp up is a little bit slow. So, so not all states are kind of of those 11 states plus DC, not everyone is completely there yet in terms of Medicaid enrollees broadly getting those services, but they're in the process of implementation. There's 4 states that are like just a little bit behind. They're going to implement coverage, most of them later this year. And then there's another 13 states that, as I mentioned, are taking some kind of adjacent action. You know, I will say in terms of things to, you know, I think some interesting things to watch, sort of some trends that I've seen in particular this year. And I think this also gets to your question, Marieke, about sort of like what, you know, what are some sort of positive aspects or kind of best practices. You know, I am seeing a growing number of states that are really being more thoughtful about sustainable and equitable reimbursement. So this follows on the heels of Rhode Island, which implemented a $1,500 Medicaid reimbursement rate starting in July 2022. Oregon also newly is implementing a $1,500 reimbursement rate. This was after really languishing for many years at a reimbursement rate of $350. Washington, D.C. Has implemented Medicaid coverage for doula care. It's up to $1,950, inclusive of labor and delivery, and if each of the 12 prenatal and postpartum visits are utilized. And then most recently, just last week, the New York State Senate approved a one-house budget, which would have Medicaid reimbursement of doula care at $1,930. The governor still has to approve the budget. But I think more broadly, my hope is that more of these states that are in the process of implementation will take this sort of $1,500 to $1,900 as the starting point for the reimbursement rates, and hopefully we can go up, you know, even from there. You know, just secondly, really quickly, another thing that we're seeing is kind of an effort to expand access to doula care in the private insurance context as well. So just once again, just calling out Rhode Island right now is the only state that is already requiring private health insurance plans to cover doula care. This was passed alongside Medicaid coverage for doula care in 2021. But this year, legislators in several states have introduced bills that either require or encourage private plans to cover doula care, including some legislation in California, Massachusetts, Missouri, New York, and Virginia. We just published a blog post with some more information about this, which I'll put in the chat in a second. And then lastly, you know, I think interesting that a lot of the states that either have implemented or are implementing Medicaid coverage for doula care, we're also sort of seeing the growth or emergence of doula groups, co-ops, associations, collectives that are really doula self-organizing to help address some of the administrative burdens that kind of come with being a Medicaid provider, right? There's a lot of bureaucracy, there's paperwork, there's billing challenges, you know, coding that doulas have to learn. And I think doulas who are new to the Medicaid system are often finding that they're needing a little bit of support, not just to navigate the system, but also on an ongoing basis to be successful in accessing that reimbursement. Oh, Marieke, you're muted.
Thanks, Amy. It is really welcoming to see, indeed, like Rhode Island and Oregon, like others also mentioned in the chat, that there is a greater concern of thinking about reimbursement a little bit more on an equitable basis, especially considering sometimes the many, many months that a doula may spend with a client, their family, partners, or part of the community. Paula, so I asked Amy to share some sort of best practices or some trends to really watch for. On the flip side of that, would you have any concerns or insights regarding the way birth doulas can be supported on a much more sustainable way? So what would be a concern that you would love to see addressed in conversations regarding, for instance, Medicaid reimbursement or supporting the birth doulas more general?
Yeah, I think, you know, when we talk about Medicaid reimbursement, it's a really important tool for increasing access to doula services, but it is one tool of many things that need to be thought about when we're thinking about the systems that are impacting both perinatal inequities, but also doulas, you know, the doula workforce themselves. And we know that that within Medicaid, you know, a lot of times reimbursement is what's kind of discussed around what is needed to support the doula workforce, but that there are many other pieces that we need to think about in terms of some, you know, and I think Amy, you brought this up a little bit, but policies around the educational or certification requirements that might be that come along with Medicaid. Medicaid is a system that has, worked in a specific way to reimburse licensed providers. And part of that has come along, part of what comes along with that is the certification education requirements. And some states are working to address that through, are doing a great job really incorporating and bringing in community-based organizations that are already doing that that education that's relevant to the communities in those areas. But other states have, required specific kind of larger organizations that many community-based doulas find are not, covering are expensive, first off, and are, prohibitive for many to even access, and then also are not necessarily covering the educational components that are relevant to the communities that they're serving. And then I think the other piece is that there are other systems that Medicaid cannot address, right? That this can't address the underlying systemic racism and discrimination that both doulas and their clients are facing in the health system, and that has to come alongside and be continuing to be worked on in the course of increasing both access to services, but also supporting the workforce, because we can't keep asking, increasing access and then asking the doula workforce to continue entering these spaces that are harmful. And I think that when we're that sometimes the Medicaid conversation can end up being very outcomes focused, and we kind of lose sight of some of these other systems pieces that need to be addressed. And then one other thing, and I'll pause, but is just around provider education and provider resistance, right? So there's issues, in respect to providers can really end up also being a gatekeeper sometimes, especially if they're the first people that somebody who's pregnant sees, to accessing services. So if providers aren't on board, even if somebody's accessing the doula, the additional work that potentially the doula has to do to address resistance with that provider, taking away from the focus they can have on their client, et cetera, is something that needs to be addressed either within the policy or alongside it.
Thanks, Paula. So what I'm taking away is really the concern, and it's also expressed in the chat, to which I will turn in a little bit, is the risk of using Medicaid reimbursement as the panacea to address so many more systemic problems. And the conversation should not be focused solely on Medicaid as the way to support both the birth doulas as well as a way to reduce maternal health or to improve maternal health outcomes, because that focus on Medicaid alone is really sort of shutting off other conversations that need to take place. Grace, you've been also very instrumental in researching the doula workforce as well as how to support. Like Paula, what would be a concern or a best practice that you would love for the audience to take away from for today before we start a conversation in a more broader sense?
Yeah, I think from my background as a health workforce researcher, I think that a lot of the research, as Paula was saying, is outcomes focused, but not necessarily on the doulas themselves. So that's a gap that I see, and kind of like I think would be a good best practice going forward at like kind of any stage, whether it's policy or research or whatever, is focusing the doulas or focusing on the doulas and, including them in the research or including them in the policymaking process. I think that's important. I also kind of prompting some questions for the audience from like a health workforce research perspective. There are some gaps that I see in the research. So like Paula was saying, other than Medicaid, like what are some additional policies or solutions that could help increase access to doula services while also supporting the doulas and, making them the focus of the policy as well. I think that there's some work that could be done on the impact of these Medicaid or state level Medicaid policies on doulas and the workforce as a whole. And what comes with that is kind of this formalization of the workforce as they get integrated into Medicare, because doulas see themselves as often outside of the, the healthcare system and the healthcare workforce. So kind of how Medicaid is bringing them in and kind of their impressions of that. And then, Paula and I have an interest too in our roles as health workforce researchers at our center and how doulas are impacted by maternity care deserts, or how doulas can help close those gaps in some of those areas. So yeah, I'd love to hear from the audience on their thoughts of that kind of research and where to take, like, what are next steps that we can do to kind of highlight these issues.
Thanks, Grace, for highlighting indeed, and a very strong takeaway, right? There's a focus on health outcomes addressed potentially through Medicaid, but there is not enough attention and conversation with doulas who are actually doing the work, who are in the communities, who know their communities, who are part of the communities, and understand that the disparities are so much wider that just a single focus on reimbursement cannot sort of take into account. Before we have quite a number of comments in the chat. Is anyone who wants to in our panel to comment briefly regarding what other people have said or strengthen before I turn to the audience?
Just adding on to what Grace was saying, and just a sense of like a lot of the conversations that we've had, specifically in California, where my nonprofit is, it's been an understanding of access being very important, right, for the people who need doulas at whatever space they're in. But what definitely has been lost, in my opinion, historically, has been the actual sustainability of the doulas doing the work, and like how that actually works for them. Like some of the issues that we've had as we implement Medicaid into my nonprofit is like reimbursement time. Like, when is someone actually get the money that they worked for? In our system before, people were getting paid within 2 weeks. And then with the reimbursement rate, we're like, okay, when you get the money over to us? And then also we're a nonprofit, so we don't have a lot of money sitting around to give it to them. And so that makes us think about, okay, if it takes 2 or 3 months for them to get their money, then how does that actually sustain their life? And then also in that process, you start to move out the people who need to be a part of this program, as far as the doulas, and you start really only pushing in the people who have the privilege to be able to work with that process, right? So I think it's like, thinking about the front-facing piece as far as the clients and patients that we want to serve, but also like, what is the sustainability and the structure for the doula to be able to maintain working within the system without being in deficit in their own lives.
Thanks, Sabia. There are also some comments that sort of pointed it. So dear audience, please feel free to raise your hands or add comments. I'm going to go through the comments and try to kind of make sure we address them. So one of the things that has been addressed in the chat is also this focus on Medicaid, but it not being sustainable for doulas themselves. So Sabia, in your experience, and other panelists feel free to join as well, what would be other ways in addition to Medicaid that would address or support doulas in a much more sustainable way? So both the doulas who are doing the work, who are in the communities, providing all these services, and acknowledging indeed that they're working in a health system that is not conducive neither for them nor for their clients. So in your experience, what could be sort of a best practice to support that sustainability beyond Medicaid?
Yeah, so I think, for me, it's like thinking about how to answer this question in different ways. I mean, I think that like, obviously there needs to be more funding in different spaces and all that kind of stuff. And maybe that can look like funding and support from different spaces. But for me, it's really like when we build benefits like this, we have to build these bills and policies based on the wellness of a doula first, and then let that push out, right? Because if a doula is being sustained, being able to take care of themselves, able to get what they need, then of course that workforce is going to continue to multiply and build and grow, right? And that means also that the doula will be able to come into the space healthy, ready, alert, you know, feeling, you know, happy to be there, right? So I think what my thing is really like, we start from building it from the doula's needs, which will only increase the accessibility and wellness and quality of care for the people that are receiving it. I think a lot of times these things are built from a model that is really about, you know, the business of insurance and how do we make this work and how do we put this over here? And it's also like a process of trying to put, you know, doula work, which is like a circle, into a square and saying, hey, fit it together. Right? There are very distinct differences in the ways that doulas practice, and that's also been the gift of what we bring into the situation, right? But what can't happen is that, and what I see happening and don't want to see more of, is that because we're trying to fit a square into a circle, the pieces of doula work that elevate us and make us what we are is then being drowned out, right? And then that creates more resentment, and that creates more hardship and for doulas to even stay in these Medicaid programs. So for me, it's just like, focus on the doula, focus on what they need and build from there, understanding that if you build from there, it will only benefit the communities who are receiving the work.
Thanks. Any other panelists who want to expand upon it? I think it's clear. So one of the few of the comments indeed also address that element of also how to work with, you know, very distinct autonomy of doula care. Part of it of insurance companies coming up with the codes and choosing the modifiers, and thereby also controlling the financial reimbursement system. So I think, so what I read in some of those comments is indeed about how to also cherish the autonomy that doulas have and need in order to do their work, and how policies may be able to also keep an eye out on that. Anyone in the audience who would love to respond, or people in the panel, please go ahead. You can raise your hand or add additional comments in the chat.
I think you know, just one thing to add when we're thinking about the, you know, the doulas as, you know, outside of what is kind of the system that Medicaid is typically used to working in, right? And that there is flexibility there. And I think that's oftentimes like, you know, beginnings of doula Medicaid, or expansion of Medicaid to cover doula services, kind of was doing like standard, this is how we always, you know, this is the process for reimbursing for Medicaid, and that there's actually a lot of room and to do that differently when we're thinking differently about the group of workers that are being reimbursed. And I think, you know, I'd heard I'm going to blank on the name of the perinatal community health workers learning series that is going on right now by the Center for Medicaid Innovation. And there was a speaker from California there who was just talking about one piece that's important to remember is that, you know, there's the language of like policy and insurance, and this is kind of what Sabia was bringing up too. And there's the language of, you know, the doulas that are doing the work, and those don't always connect, and needing also support in that process when we're thinking about a doula focused policy, that there needs to be work to help both, you know, both groups understand, but also be open to different pathways to getting to the place that we want to get to. And I think, yeah, and it was, Sabia already said it well in terms of this, when this starts from an outcomes versus a doula focused place, automatically run into problems, and you need doulas for policies like this to work. So, and continuing to keep in mind, I think that doulas are one piece of many things that we need to be thinking about that need to be addressed when we're wanting to address perinatal inequities. And, another big piece is kind of the whole model of care around perinatal health, right? And that we don't default to a midwifery model that we know has better outcomes. And so, anyway, so I'll just pause there. It's not like a specific answer when we're thinking about, say, insurance codes, but I think all of that comes along with kind of thinking big picture about the pathways that we're taking to get there.
I also say, just to piggyback off what Paula just said, I think that's right. And I think also for state Medicaid agencies and for sort of legislators and health plans, I think another way that they might think about this also is that they really need to support the doula workforce, right? Like, I think it's one thing to kind of roll out the benefit, but I think what we've seen is that in states that kind of are trying to implement Medicaid coverage for doula care without doing that in partnership with the doulas that are going to make up that doula workforce, once the benefit goes live, the enrollment numbers are very low. Doulas either are not willing to sign up because they can't figure out even how to do the enrollment, or in some cases, the reimbursement rate is so low, it's not worth it for them. They'll say, I'm going to find other ways to try to serve this population because I'm committed to serving low-income clients, but I'm not going to do it through, I either can't figure out, or I'm not going to do it through the state Medicaid bureaucracy, which is going to really, dilute the services that I provide. So I think, in contrast, in states that have really worked in partnership with the doulas, and I should say, like, in some cases, it's not like the state Medicaid agencies necessarily know how to do that. A lot of times it's been a process, right? In California, it was definitely a process. Those early conversations were very challenging, ended up getting a facilitator, towards the end, I think there was just like much more common ground. But I think in states that have worked more collaboratively with the doulas, and not just like gotten input or feedback from the doulas, but really worked in real partnership, I think in those cases, the doulas are connected. They understand what's going on. They have an understanding of the benefit. The state understands how to integrate them. And so in those cases, doulas do enroll, right? Doulas are enrolling, the utilization numbers are higher. And so I think it really is, from the state perspective, I think just as Sabia said, like, you can't just, yes, we want to roll out this benefit for the Medicaid enrollees. This is a life-saving benefit, but also you need to set up a system that is going to work, not just for the Medicaid enrollees, but also for the doulas providing the service, because that is going to be your doula workforce.
Yeah, I think that's like, I love having this conversation. And I would say too, like, I think sometimes there's maybe, I was talking to one of the insurance companies that we work with in my nonprofit, and they asked the question of like, why are doulas against this or in fear of this or whatever? And I was like, it's not like, we as doulas, and I think I can speak generally, we want people to have access to our services. Like, absolutely 1000%, right? But we can't get away from looking at different models of, birth work practices being integrated into the medical system and them being lost, right? So when we look at midwifery, we look at that process of like, hey, we were doing our thing, it was cool. And then once it entered into the system, a lot of people were left out of the conversation. And even now, years and years later, we still see a lot of people having a hardship with getting in there, right? And staying there and being healthy in there if they do get in there. So I think like in these conversations, we have to always name that the reason why we're not debating, but having conversations about this is definitely about reimbursement and sustainability. And it's definitely about access, but it's also about not wanting doula work to be erased in the ways that we currently practice it and have been practicing it. And I think like that's the thing that we all want to bring together, is like, how do we create access, sustainability, and keep our practice true to what it is, right? Because it exists alongside of the medical system for a reason. It is the way that it works is for a reason that has been very helpful. So helpful that Medicaid and whoever wants to be a part of it, right? To be a part of it needs to allow it to flourish, to continue to support it, right? But not to change it and shift it into something that we can't recognize any longer.
Thanks. I think that is a really beautiful phrase, right? Beautifully phrased. Increase access, focus on the sustainability, and cherish and also support self-determination of the doulas in carrying out the work that they do. There was one question regarding that was entered in the beginning. How to frame, how is the Medicaid allowability being seen, especially when some organizations may say we cannot pay for doula care because it is medical, but at the same time, doula care is not medical. It is so much more. It's that really that breadth and the scope of services. So how is it possible? So what are some of the arguments or the support provided to have Medicaid see or the allowability of doula services as it being not medical? Can someone respond to that?
I can try to take a stab. I think from my perspective, maybe it's because there was so much research initially on the outcomes of doulas, like in their positive impact on birth outcomes, like in medical terms, potentially. That kind of made them eligible for Medicaid expansion, potentially. Not an expert, but that was just kind of my first thought, was because of all that focus on positive impacts on birth outcomes.
And then a different question. So a lot of our conversation has rightfully focused on when we're talking about doula care, it is not the health outcome that should be the focus of the conversation, although it's important. It's really supporting the doulas, make sure, right, help them to be healthy, to be ready, to be alert, to be fed, to have housing themselves. So really support their own sustainability. In all of your expertise, what can states do to make sure that they include doulas in their conversations from beginning to the implementation of the process, to the evaluation, and also to continue having conversations about doula care and not have those conversations stop once Medicaid inclusion has been launched. So what can states do to really make sure that they are not talking about doula care, but they're talking with doulas about the care that they provide?
I was going to say, I think people like states, whoever, have to expand their definition of impact and what factors into impact. I think, historically with doulas, of course, people look at the impact that we have as far as, medical outcomes and decreasing of this and lactation of that. But I think there has to be an expansion of impact that also is like the health and longevity of the doulas, right? So like, and that will give more of a full, complete picture of things that we need to factor in when we're making these decisions, instead of it being really just based on the client's outcomes.
Thanks. Also, Raven, I see your hand. Feel free to comment or ask your question.
Hi, it's a little bit of both. I can just say, like, from the Oregon perspective, like, I think it was helpful for us that we weren't just doulas alone. They kind of housed us under community health workers and peers and navigators. And so it wasn't just like a few doulas screaming into the ether till somebody like paid attention to us. It was, excuse me, like, we had a whole cohort of people who were non-clinical, community-based, like all kind of aiming at the same goals, but through different pathways. And I think that really helped create a louder voice. And then the state, I feel like the state is slow and bureaucratic and terrible in a lot of ways, but that they were able to really integrate and create like seats and regular, like legally required to have input from doulas, from community health workers, from different community doula-based groups. And so I think that was really good. I'm curious like what other states are doing, if it's sort of like, yeah, some states are really well organized and some states are like fighting doula input, or I don't know. And yeah, I think I had other thoughts, but that's kind of all I'll say for now, I think.
Thanks, Raven. Amy, could you potentially speak to Raven's questions? Like how are other states doing it?
Yeah. I mean, I can say that in some states, you know, I would say, I guess addressing sort of your initial question, Marieke, I would say, you know, it's important to have some kind of, you know, permanent, whether you call it an advisory board, an advisory committee, but some, you know, permanent group of doulas that are continuing to work with the state, troubleshooting, implementation issues, what have you. I would say another really, really critical thing that I unfortunately have not seen in many states yet is that there really needs to be funding for that group, right? So like, you know, in many cases, you know, state Medicaid agencies or like advocates like myself, we get funding to do policy work. So this is something that I do as part of my job. But when you're asking doulas to come to the table and review whatever state plan amendments, review regulations, that's taking time away from time that they would otherwise be spending with their clients, right? Paid time. And so I am seeing, unfortunately, in a lot of states, that there, you know, maybe they are convening doula groups or advisory boards, but there's no payment for those boards, and that really is work. So I think that would be a key piece, you know, having some sort of regular body that is kind of providing that support. And then, like I said, the second big piece, having them be funded. I've seen, you know, some states have required the formation of these advisory groups in legislation, which I think is good because then it's mandatory, it's required. I think other states have, you know, done other things.
Yeah. Thanks. There are sort of two comments. One is, for instance, mentioning Oregon has a foundation of Elder Mama Sabia, and I hope I pronounced it correctly. And her trainings were integral in being one of the first states to have doula reimbursement, all it being low, but it did make a huge impact to Rhode Island and moving our work there. There's also a concern, right? Indeed, and also, again, also in the audience, confirm, please compensate the doulas as you would any policy consultants and subject matter experts, right? Time and expertise is to be funded, and doulas have incredible expertise, especially doulas serving underserved communities and BIPOC communities and low-income communities, especially also because a lot of the training by larger organizations do not provide sort of culturally sensitive training that clients and doulas need. There's another concern that I would love to end our conversation with, since I want to be respectful of your time. One comment is states won't know what doula work is by reading articles. And so my question to whomever wants to respond to it. So what is a good practice and best practice to really, again, to make sure that those who are designing the policies, who are thinking of including doula care in any kind of policy, what is the best way to make sure that they know the incredible and life-saving work that doulas are doing?
I think that when we look at paper, right, like it can tell a little bit of something of what we do, but I think really the magic of understanding what we actually do is in storytelling. And I think storytelling has to be a piece that is brought to the table, and storytelling from the aspects of the people that we work with, as well as the storytelling from the aspect of the doula, right? Because the client, you know, they give the details, right? But the doula also said, like, this is what was happening for me in my life in the background while I was also moving through this with them. And I think storytelling can be something that really helps people to put pieces together, more so than paper, which is so like complete. So I think like people have to, like, in any of these policies and things that we're talking about in that creation, like storytelling happens when you engage with the actual communities that are doing the work, right? And if there's no storytelling, it just tells me that you haven't engaged with the actual community that's doing the work. And so that's already bringing up a foundational issue. So yeah, that's my thought.
Thanks. Any others before I go to Raven? No. Raven, go ahead.
I totally would ditto what Sabia said as far as like storytelling. And I think a lot of the times it's also just seeing how it works out, because a lot of, especially providers, I don't know, they're just so like paranoid and how they conceptualize doulas like taking over or something, or anesthesiologists being so unreasonably threatened by doulas. Like I had anesthesia tell us like, oh, we feel really undermined and marginalized by doulas. And I'm like, dude, you're there for 20 minutes. You're the god of the OR. Like, how are we undermining you? So there's a lot of just like fear and all these conversations happening all the time. And like what we've seen is just like show up and be consistent, and having our doulas just be on the floor really regularly, to the point where we're doing like a really short trial run where we're having, and I don't even philosophically, I'm not like thrilled with the idea of shift doula work, but our doulas were actually like, that adds some sustainability for me right now as far as the pay. Like I love knowing when I'm getting off, and I love knowing how much I'm going to make and get it like right now, instead of, like as a hospital, we can pay them within 30 days, but even that's still like kind of, it's better than the state, which is 3 to 6 months sometimes. All that to say, it's been really interesting and dramatic to see. I thought like, oh, the midwives will be our friends and allies, and the OBs and the hospitalists will be like suspicious. And it's been like the hospitalists and the most like medically intense providers who love doulas the most. They're like, oh, you guys know stuff I never learned, and I don't have time to do labor support. I am so thankful when you guys come in and you're just like supporting that person. You know their partner's name. They're like, we've had doulas pull people out and be like, their pronouns are they, them. You need to get this right. Or like, you cannot say that to this person. And just like the doulas having the ability to have those conversations with providers, and providers being like, oh, crap, yeah, thank you. I didn't know. This is like my 8th patient in the past 4 hours, and they're just going through. So having that regular interaction with doulas and having that normalized and be like a consistent thing builds those relationships. And then providers are like, oh, okay, I see how we can work together. I see how this isn't as threatening as I thought. I know I had that one wild card doula who is actually like an angry grandma that one time, but now I can replace it with like 20 other examples of really good doula care that I have seen, and have like my patients are like less traumatized by my care, and patients saying that.
Yeah, thanks, Raven. One of the things I would love for everyone to take away who's still on the call is really, again, start with the doulas in any kind of intervention you want to make. Listen to their stories, ask for their stories, compensate them for the work that they do, not only in designing policies or the intervention, but also really think about sustainability of what they would need to continue to help their clients, as well as remain healthy themselves, and as well, and also continue to grow and catering to their communities. I want to thank everyone for being here. I want to give Sabia, if you would like to, can you promote your book? Or if you want.
Yes, my book, Birth and Liberation: How Reproductive Justice Can Set Us Free, is now available. And it speaks to anyone who's living, because we're all born. So definitely, if you can take some time out to read it, go through it. It talks about the history. It talks about a lot of what we talked about. And I think even this conversation will make a lot of sense in the space of like reading the book and learning about historical things that are impacting us today.
Thank you so much. I'm looking forward
Thank you.
to reading it. Thank you, Amy, Paula, Grace, and Sabia, as well as Amy, Matt, and Trish for bringing us together. And in the chat, the bottom is a link to the book. Thank you all very much for joining us today. Thanks.